Hey, Mark, how you doing this evening?
Guy, I couldn't be any better. It's good to see you. Where are you at tonight? You're not home. I can see the
No, I just got here a little bit
wallpaper
ago. I'm up
different.
in Cape Cod visiting a good friend of mine, Dr. Bill Shire. We're going to be hanging out in his office next few days,
Oh,
and
nice.
little late on the flight, but happy to be here in my hotel room and here at the where am I at the Chiquette Beach Motel. It's very exciting, but
Easy for
I'm
you to
excited.
say. Easy for you to say.
I think I've probably butchered it actually, but I'm Dr. Guy Yatros. I got my good friend, Dr. Mark Murphy, one of my friends and mentors that I've known for quite a few years, ever since attended Pankey Institute with you years ago. As actually as my first Pankey instructor, and I've always admired your passion, the way you care about the patients, and in
Oh,
particular,
thank you, Guy.
I think one of the things you do really, really well is because you care so much, you do a great job at the initial consultations back when we were doing restorative, and now with sleep, it's even more important to be able to sit down with your patients and to find really the best treatment for them. And I'm excited to get to spend this hour with you to kind of hearing a lot of the things that you do to help get patients to say yes to treatment.
Well, thanks, Guy. You know, it's interesting you point that out because for me, being a dentist like we all were, and then transitioning over to sleep, there weren't as many parallels as I thought. But one of the parallels, you and I talk about the learning ladder: unaware, aware, interesting, belief, a commitment, and trust. We talk about helping the patient, understanding their journey, understanding our journey. So some of those things did transfer over. And so in the last, I don't know, maybe 6, 12 months, I've been spending a lot more time on this, and I've been helping some other dentists. And so I think we do have a few things we can point out tonight that really can drive and improve getting those patients to say yes to treatment.
Did you say we weren't dentists anymore? Is that what I heard?
Well, it's funny. It's funny. I explain that. I explain that to
Okay.
patients all the time because I just do sleep and you just do sleep.
Right.
So I say to patients, well, I'm not really a dentist anymore. I go, and I'll say something like I played one on TV or I stayed at a Holiday
Right.
Inn Express, everybody laughs. I go, I only do dental sleep medicine now. And I really try to make that clear because I don't want the patients that are referring to me from other dentists or
Right.
from physicians to think, oh, and I'm going to be their dentist and do their fillings, their crowns, and all that kind of stuff. So I try to make that very clear.
Yeah, and it became clear to me when I had to pay for a crown on my wife's tooth not too long ago. So, God, these dentists
Ooh.
charge a lot of money, I'm telling you. But anyway, I'm happy to be here. I think we were going to start, we've got a lot of information to go through. If you have questions, let me close a few boxes here so I can see. Type them in the question box. We have our whole team of dental sleep experts will be answering those questions. Mark and I will answer. Is there any way to turn up the volume? Okay, I don't know. I think we're maybe on that end.
So, Guy, you've got control of the slides, right?
Yes, I do. So
Okay.
we'll answer your questions as we go through, and we'll type those in. Just keep them coming, and we'll talk a little housekeeping later about how you get your CE. So you had something you wanted to say? I'm sorry if I interrupt you.
No, you're good. You're good. Because you got control of the slide, so I'll just remind you when to go to the next slide. That's good.
Okay. Are we ready to go to the next slide?
Yeah,
Okay.
do it.
Well, I think we were going to start with you and I talked about and collaborated about how you do this, how I do this, and the 6 points that you'd like to make about how you do this. And I said, well, can I go first? And you were gracious enough to say I could go first. And
we only have an hour. We only have an hour.
Better hurry up. And all my points are pretty similar. I say this in somewhat jest, but in all truthfulness, actually, is that the number one thing that I see when dentists are challenged doing dental sleep is within their own belief system. They have to believe that they are the right ones to do this. They have to believe it's their job. They have to believe that it's within their abilities. They have to believe that this is something worthwhile doing. I mean, I have a lot of beliefs on here. And I know, Mark, you're going to give us a lot of really specific things to do, verbal skills, steps to take. But when we discussed this, I said, this to me is 1 through 6. All these things you're going to bring up, I know are going to help because it gives you the tools to do it. But without the belief that this is my job, it's my obligation. Shame on me if I don't look at my patients for screening. Am I going to let someone possibly suffocate, choke to death, or increase their risk for heart attacks, strokes, and all these things? It is our job. The ADA says it's our job now. Wake up. Dentists, we need to be doing this. And if you believe in this, then it becomes real easy, because what kind of patient wouldn't pay a few $100s to see if they're going to choke to death at night? what kind of a person wouldn't put a mouth guard in or maybe even a CPAP to keep from choking at night? Once you believe in what you're doing, it becomes a lot easier. So, see, that didn't even take a half hour, Mark. That was a whole lot less.
I thought
time.
for sure. So, Guy, you couldn't be more right. And we did get a chance to talk about these slides and put them together, and it was really fun collaborating with you on this. And you're let me say, I'm going to cover a much more practical sequencing of my 6 steps, but your 6 steps, although a little bit repetitive, your 6 steps are really where the rubber hits the road, because just like when we do think like a dentist and we think about restorative dentistry, and most of the folks out there who are doing sleep are also doing some restorative dentistry. So you got to be able to look at a patient and think to yourself, what would I do for you? What would I recommend to you if you were my brother, or you were my sister, or you were my mom or my dad? What would I do? What would I do to my own mouth? And that's the same thing here. You have to believe that I should, must, can, will, and are, and have done this, because I have to believe this is the right thing to do. I have to believe that I would do this for myself, for my wife, for my family, for my friends. And you just apply that same philosophy to your patients. Now the switch starts when, there's medical insurance and it's much more of a necessary kind of activity. Maybe you could argue dentistry still has a little bit of a discretionary component, good or bad, but you really have to believe this. So I appreciate your perspective. That's important.
Yeah, and I think you're going to give us the 1 through 6 on the maybe more like the tools and the skill set that you need. But I can tell you, I believe in it. I wear one of these devices every night myself. I have for almost 20 years. My mother wears one. My father, while he was alive, wore one. My wife doesn't need one, or she would be wearing one. So I mean, it's absolutely something that I believe in. And once you get through that, then like I say, all these things will fall into place. And I'm really excited to hear your steps. I went ahead and advanced it there. I think that was what you.
That's perfect. Perfect.
Yes.
So before we talk about my 6 steps, I want to give us a little bit of perspective, because when I think about sequencing and putting together these steps, I think, unfortunately, a little bit more like a business person, an analyst, doing gap analysis, pretending I'm getting an MBA. And I'd be thinking about, what does the perspective look like from where I'm sitting for what we're trying to do and how we're trying to get patients to move through the system and say yes. And then also, what does it look like for the patient? Because it can be very, very different. And although we do want to accomplish what we want to accomplish, the more we can get inside the patient's head and heart, the more likely we are to help them go along that pathway. So let's switch the slide, and I'll talk a little bit about my perspective and what I'm thinking when I think about the different activities. Now, you're gonna dislike these words. A lot of people do when we talk about selling dentistry or selling Crown and Bridge, but please get past that for a minute. It's just going to save me a lot of time. I could talk about helping patients want what we know they need. We could go on and on. But if I look at patients coming into my practice, and I look at the sleep part of my practice, and I look at those patients, I could look at seeing those patients, trying to get them tested, trying to get them to accept treatment, trying to get them to complete treatment, trying to get the follow-up test, all that kind of stuff. And I could see that as a sequence of events. And if I start to look at that as a sequence of events, I realize that there's a couple different pathways that are a little bit different. And so the first thing I would think of is that when I look at this funnel, it's a giant sales funnel where there's a bunch of patients at the top. Some of them say yes to the testing. Some of them say yes to the appliance. Some of them do the follow-up testing. And it keeps getting narrow. We never get 100% conversion at each level. That's okay. That's okay. But what we want to do is we want to help as many of the people who are up at that top level get down to the bottom level to get tested and be in therapy. And so there's 2 different pathways to this funnel. So I kind of have 2 different funnels. One, and gosh, you and I both have some friends. Your practice is more like this. About 1/3 of my practice is referrals from physicians where the patients walk in and they already probably have a sleep test, and they usually have an RX. They're ready to go. They've been told they need an oral appliance. They failed CPAP, or they're mild and moderate. They're not going to get a CPAP.
Right.
And they've come to me for the oral appliance.
Right.
There really isn't so much of a sales to do. People who's just about 100% of those patients are good. And so that's one pathway that a patient comes to me. But that's only about 1/3 of my patients. About 2/3 of my patients come to me on referral from other dentists. I work in 3 different locations. I have 2 dentists who I work out of their practice, and then 1/3 is an endodontist. And in that endodontist practice, I have about 12 different dentists who send us patients. And so a patient comes in who's been referred by a hygienist or a general dentist who says, talking to you, I think you snore, you've got some daytime sleepiness, our screening exam, just doing a great stuff like you recommended that ADA has told us to do. that patient has been identified at risk, but that dentist does not do sleep. So they said, go see this guy and see what he thinks. So now I've got to take that patient down a pathway that says, I've got to, I hate these words, I've got to sell them. I'm doing a sleep test.
Right.
And if they come back and it's positive, I've got to sell them on oral appliance therapy, or sell them on CPAP, or sell them on positional, or surgery, or whatever you think is the right solution for them. And then we've got to make them that appliance, deliver that appliance, educate them, titrate them, get them into therapy, and then do a follow-up test. So I've got to sell that patient. So there's two different pathways. So my goal and objective is to say, what do those different pathways look like, and how do I do little things or big things, but usually they're little things that help that patient say yes to the sleep test, that help that patient say yes to the therapy, that help that patient say yes to whatever their co-payment or out-of-pocket expense is when it comes to insurance. And if I'm looking at those two pathways and I'm looking at all the different steps and seeing how I impact them, then I want to measure my conversion from here to there, from here to there, from here to there. Why? Because then when I make those changes, I can see that improved, or did the metrics get worse and get those patients to closure. Does that make sense?
Yeah, I mean, it makes total sense, and I think the big thing is the measuring. A lot of dentists fall short there, and if how well do you know what you're doing works? And if you don't measure it, you'll never improve it. If you want to run faster, back before when I could run before my knee was gone, I think yours are too nowadays. Back when we could do those things.
Oh yeah.
Look at your watch, and you got faster. You measured it. So I think all those steps are important, but I think where we fall short when we do consulting and things, we don't measure. And to reiterate what you're saying is you have to have systems in place so that when someone contacts your office, that you know which funnel they're going in. Are they going into the non-diagnosed or previously diagnosed? Then you have to know what the goals of each of those patient interactions are. The first one, if they weren't diagnosed, is to get them diagnosed. That's it. We're not treating them. We want to make sure. We want to know if they're choking to death at night. That's it. And then the next one, once we know that they have an airway problem of apnea or something like that, then we need to talk to them about treatment. I think a lot of people go from you're snoring, here's a device, you probably have apnea, and they start mixing all those two together. You got to have separate systems, and everything you have here is just perfect. I've learned something already, as I knew I would.
Totally agree. So on the next slide, we're going to talk about what does this look like from the patient's perspective, and that's going to be a little bit different. Now, the patients, we think, are worried about different things. I say this, I use this example all the time, but when my kids were starting middle school, we went to a meeting at the middle school. We live in a very nice neighborhood, nice bedroom community outside of Detroit, Michigan. It's called Rochester Hills. And we went to this meeting and had all these middle school parents, and they had the kids over in another room, and we're in this room, and they asked us to write down it, and we talked about as a group all the things we were worried about. And we were worried about the kids smoking. We were worried about sex. We were worried about drugs. We were worried about behavioral issues. We were worried about some pretty serious things. And then the school brought us the list of things that the kids were worried about in the other room. The students were worried about how would they find their classrooms? Would they like their teachers? What were they going to have for lunch? Totally different levels of importance. We had this view of their reality that was very different than theirs. And I think that happens to us sometimes when we are dentists doing dental sleep medicine. As dentists, we're used to dealing with discretionary expense. There is no such thing as dental insurance. There's a dental maintenance plan. There's a dental payment plan. There's a coupon, a discount, whatever you want to call it. But insurance is when a third party takes the risk for catastrophic loss, and $1,200 or $1,500 is no catastrophe.
Right.
Most people's dental coverage stops long before medical insurance kicks in with a $3,000 or $5,000 deductible. So the patients aren't looking at the medicine the same way they look at the dentistry. And so they're asking 3 questions. They've been surveyed. Patients have been asked about disease management and their problems. And in medicine, it's well known that patients want to know, do I have this disease? Do I have a heart problem? Does my knee, do I have a problem? What's the deal with my knee? My knee's sore. Do I have a meniscus tear? Do I have this problem we're talking about? So I know that there's going to be some diagnostic testing and everything. We're going to do I have this problem? And once I find out I have this problem, how serious is it? Is this going to kill me? Is this like threatening? Do I have to live with pain? What are the ramifications of treatment and non-treatment? And then finally, can you treat it? Is it curable or is it manageable? And so whether that's a torn ligament in knee, whether it's a heart disease, whether it's hypertension, and some things, arguably, some things are harder to convey the seriousness. If they have hypertension, they might think, well, I don't feel anything, I feel okay, but you've got to know the consequences. So really, they want to know, do I have it? Is it serious? Is it treatable, curable, manageable? And I hear most dental sleep medicine dentists talking to patients about co-payments, deductibles, financial arrangements, how much is going to be covered, what their out-of-pocket expenses. I would focus on answering these 3 questions. And so when you see my 6 tips, we're going to talk about how that helps my perspective, funnel management and metrics, and how it helps their perspective, getting that patient to want what we know they need. Next slide.
Yes, I agree with that. And what I say to this is take off your dental hat and put on your medical hat. You just got to look at it through the medical. We're not going to give these people a 7-page treatment plan for this in the 3rd appointment. We're going to get them, you come to the doctor, you go through those 3 things, and then they tell you what you need right then, of course, unless they need further testing. So take the dental hat off and put I'm a doctor now. And I think that kind of summarizes what you're saying there to some extent.
And that's a good point, because it's easy for me, it's easier for me, it's easier for you, it's easier for Richard to take our dental hats off and put our medical hats on, because that's all we do. And so it's easier for us to grow into that new person. It's harder. I was in an office on Monday with a friend of mine that does dental sleep medicine, and she was seeing several patients that day for sleep, and I wanted to check out her scanner, her pharyngometer, and a bunch of stuff like that. So we were there, and she also had dental patients. And so she's taking it off, putting it on, taking this one off, putting this on. She's playing dentist, and she's playing sleep medicine. And I'm like, I don't know how you do that. How do you do fast food and mix it in with fine steaks and wine and everything like that, and serving it from different tables all day long? How do you have those systems aren't very compatible? And so maybe, and I'm not suggesting this for everybody, but maybe segregating your sleep to a certain day of the week or half days of the week might make it easier to flip that switch and transition to being that hat off and hat on kind of person. So I like that thought. It's a good analogy.
And it has to be your team too. They have to be able to take that hat off and
totally.
So
Totally agree. So these are my 6 steps. I'm going to tell you all of them right now, and they'll go through them one at a time. So the 6 steps are ownership, patient ownership, of course. The second step is severity. I want the patient to really understand the severity of the disease, and that means not just mild, moderate, severe, but what this really means to them from a comorbidity standpoint. We have about 8 slides that we show almost every patient. I guess if people wanted, I'd send them those slides if it's helpful to them. They're welcome to have them, use them however they want. But the 6 slides help tell the story of what sleep apnea is, what causes it, the comorbidities, the higher incidence of heart attack. I give some examples of anesthesia, stuff like that. We go through that. But then I have to give them hope. So own the problem, know that it's a big deal, and then I have to give you hope that we can do something about it. Once we do that, then I want to deal with topics that kind of help my part of the funnel. What's the usual, customary, and reasonable way that this gets treated and paid for? And what are the expectations the patient can have in terms of treatment and follow-up and everything like that? I want to set those expectations. I want to set expectations for success and exceed them. I want to set expectations for side effect management and not get anywhere near those side effects. So I want to really control the expectation management. Next slide. So when we think of ownership, there are so many different things that I can think of. When a patient walks in, though, and their pathway was they've got a prescription, they've got a sleep test, the physician has told them that, I might still show them some slides. I try and gather some insight from them as to how much they know about their sleep apnea, but sometimes still play that educational role. But for the most part, if that patient walks in and they say, here's my prescription, I'm ready to go. I want to get to impressions that day if I can. I want to do the exam for them that day if I can. I certainly want to get them committed to the process. But so many times, 2/3 of the time for me, I see patients who come in and they've just been screened and they don't really know anything about a sleep test yet. They don't know anything about the severity of the stuff. So I start to talk to them about certain tools that I can use from a patient education standpoint. One of my favorite tools is an app that most people know about that are doing sleep. It's called Snore Lab. One word, Snore Lab. The free version lets you record 3 nights, not consecutive. It stores 3 nights every other night. I've got the $5 paid version. But this is an example. I show almost every patient that if they're snoring, and I talk to them about snoring and sleep apnea, I say, my gosh, if you snore, there's a really good chance you have sleep apnea. Here's the stop bang. We talk about that kind of stuff. But here's the kind of thing that we can do. You can record your snoring, because I'll have patients tell me all the time, well, my wife says I snore. I go, do you think she's lying? And they go, no, but I don't really know how bad it is. Well, here, record it. Get a number, get a score. And I tell them one of the things we can do, and I show them these two pictures or pictures like it. Sometimes I bring up the Snore Lab app I have on my phone and show them mine. I say we can create a significant reduction in the snoring, but our goal is to really create a significant reduction in the AHI score, and I explain to them what that is. So I want them to really own that they have this problem. Now, unfortunately, a lot of the patients and their spouses come in, and even though they've been tested, or even though they've been screened, and even though we start talking about this, they're way more concerned about the snoring than they are the AHI score. The AHI score is going to kill them slowly, but their wife's going to kill them quickly if they're snoring. So they worry so much more about snoring. So I try to make sure that we've got tools that help the patient come to understand that this snoring is kind of equivalent to having some sort of a problem. I tell them we sometimes see people that snore that don't have apnea. We sometimes people that don't snore that do have apnea. So we see mixed matches. But because you snore, you've got a higher likelihood that you have sleep apnea.
Yeah, and don't assume if they came with that diagnosis that they already know all this too. I think that would be one thing. I mean, if they came from a physician, even if they've already tried CPAP, my experience is many of these patients still have a very minimal knowledge about this. So this is worthwhile time for the vast majority of the patients.
Yeah, and I've got a little 8-slide series that I show them to give them some information, even talks about the types of treatment, but I really want to make sure that they've got a good education. You know, just like we would do in a new patient examination, I'm going to ask them questions, talk to them about it. I'm going to try and find out, you know, what is their hot button? Is it the tiredness? Is it the inattention? Is it snoring? Maybe they've got a comorbidity, they've got hypertension, arrhythmia. So there's something that we can grab onto and we can attach to create that curiosity and co-discovery that is so important to the patient experience.
Absolutely.
Next slide. So now let's talk about severity. So in the severity slide, you can see, go ahead and flip that. You can see that severity is an issue that we can talk about with patients in many different ways. We're all familiar with the Epworth Sleepiness Scale. I wish we called it the Drowsiness Scale. It has almost no correlation at all to whether or not the patient actually has obstructive sleep apnea, because there are so many different reasons. You were up early, your son's swim practice this morning, flying all day, so you're tired. Does that mean, you know, you have sleep apnea or you're not wearing your splint? Nope, doesn't mean that at all. There's lots of reasons to be tired. But it's still, the Epworth Sleepiness Scale is a great conversation starter with patients. What we did here, and this is a form that we customized, I took on the one side, you can see kind of like a stop bang. I call it an easy stop bang, where I asked hypertension and arrhythmia. Instead of neck size, do you have a large neck? Instead of a BMI, do you consider yourself overweight? So I tried to simplify the questions in patient speak that would be a little bit easier for them. And any patient that has just been screened, maybe they've already had an ESS and a stop bang at their dental office, I get this out, I put it out in front of them when we're talking. I said, well, let's take a look at what you got. And on the left-hand side, there's a little discussion about comorbidities and how serious all this stuff is. And I say to them on the right-hand side, so let's give you kind of a score here together. You know, so do you snore? Has anybody ever seen you stop breathing? And I go right down the list. And down at the bottom, not me, the scorecard, not me, but the math says if you have 3 of these, there's a moderate risk. If you have 4 more, there's a high risk. And I hand them that piece of paper. And I say, there's your scorecard. So I like to say, you have this disease. It's very likely, 90% probability. Here's your scorecard. Here's your test results. They're not really a test, but and it's for you to have in hold. So you've got to look at it. You've got to own it. You've got to really know that this is a severe problem with these things on the left, and you can't escape it. And I find that this really helps people get the feeling that this is a real disease. This is a disease that should be treated. This is a disease that they likely have, and they want to do something about it. We need to get this person, obviously, to a sleep test. And so I'm trying to create the answers to those first questions. Do I have this? Yeah, you probably do, but we don't know for sure. Is it serious? Yeah, it's very serious. I haven't given you any hope yet that we have a solution, but I'm going to get to that. And I want them to own that problem well enough so they would say, well, what do we do about this? And I always say, but even though you had a 5 out of 8 on this, and I always explain that I would get a 5, for example, because I snore, I'm overweight, I'm over 50, I've got a large neck, my BMI is big, so I get a score of 5. I go, even though I'm 90% probable when it turns out I do have obstructive sleep apnea, I don't know for sure until I get a sleep test. So I always tell them, so that's our next step. So let's go ahead and get a sleep test ordered up for you. We reach out to Ryan, sleeptest.com, boom, we get that all ordered up, and that's great. But I also want to make sure that they know this doesn't mean it's a death sentence for them. This doesn't mean there isn't something we can do. So while I'm getting them all worked up, I'm making sure that they own the problem and they know how serious it is. I also want to give them hope that there's a solution. Jump to the next slide.
Yeah, I may add one thing, two things on that. Number
Sure.
one is the process at which you do this. There's different ways. We use a tablet screener. What I like, similar thing that your system does, the screener shows the score, and then the patient,
that's right,
somehow
that's right.
they trust the computer instead of me.
Across that arrow over here to the red zone. I love
It's like,
that.
oh, the computer says you have an issue. So they kind of come to their own conclusion that they have a problem. I think that's number one. And then number two, I don't know if you explicitly said this, but what we say is, we get them to the point of when they say, like you said, how do I know I have this problem? And then it's not, do you want to, please, pretty please. It is, well, you have to have a sleep test. Which way would you like to have it done, at home or in the sleep lab? And everybody says at home, and then you move on. So just saying you have to have this, not do you want to, is a huge. That's what doctors do, right? They don't tell you, hey, we're just going to ignore this. Let me give you a treatment plan for your blocked coronary artery. They say you need to have a test. So go ahead. Those are two really, because a lot of the dentists don't get beyond this point. This is the point where a lot of the people get stopped. And if you don't get the people past the point of getting tested, then you're going to be sitting around in your office with a bunch of people who are at risk, and you're not getting the diagnosis done.
You made a good point. You said that most people would rather have the home sleep test, and so I prefer the home sleep test. I like to use the home sleep test. I mentioned Ryan at sleeptest.com. We use them a lot. I know you're familiar with. But not every patient is a candidate for a home sleep test. There are times when the patient's cardiovascular history, the complexity of the situation. I accept Medicare, so if they're a Medicare patient, I've got to send them to a physician. The physician has to order the test. I can't do it. So there's exceptions to that rule. So we're sort of a gatekeeper to say which way they're going for the test. I like that. Now, hope is an important part of the consideration. Next slide. And so what I try to do is I try to let them know that there are some things we can do about it. And for most patients who come in, they know something about sleep apnea. For the one thing in my door that are failures or CPAP denials, they don't want to do it. They hate the idea. For the other people, I say to them, do you know somebody that, has obstructive sleep apnea, has been treated with CPAP or anything? Oh, yeah, instantly these people go right to, I hate to wear that mask. I don't think I've ever heard a person say to me, I love that CPAP. Oh, they're constitutionally wear it every night and they're fabulous, but I don't think they'd like it. I don't think they like taking it off when they go to the bathroom, putting it back on when they go back to bed. I don't think they like the maintenance. There's a lot of headaches with that stuff. So I want to let them know that there's a chance we can treat them, especially if they're mild and moderate. I've got a really good success record. When we go to severe, my numbers drop down just like everybody else's do. So I do the simplest thing, and a lot of people do this, but it's not like I made this up for the patient. I said, well, do me a favor. I said, lean your head back and make a snoring sound. And they go, I go, again, that's kind of fun. They go, I go, now stick your jaw forward and make the same snoring sound. And they go, and sometimes you look down and go, that's amazing.
Right.
I go, that's what we're going to do for you. That's what we're going to do for you. So you have this problem. You own it. It's serious, but I can help. That's what I'm going to do for you. So now they've completed the 3 questionnaires that they have in their mind that says, I have this, is it serious, and can you treat it? I can. Now, if they stick their jaw out and they still make a loud snoring sound, I go, ooh. Well, I wish I hadn't heard that. They go, why? I go, because if you stick your jaw, if you can still make that sound, I'm going to have a harder time over here. Now, I could do that with a CBCT scan. I could do that with pharyngometry, rhinometry. Totally right. Those are great tools educationally. They're not diagnostic tools to tell the patient that they have or don't have OSA, but they're great educational tools, motivational tools for the patient. But even the snoring test is simple. Now, I've done all this, and it takes 10, 12, 15 minutes maximum. It's something your team could do or you could do. Depends on who likes to do the communication in the office. I want to make sure the patient is going down their pathway and they're getting their questions answered. Do I have this disease? Yep. Is it severe? Yep. Can you help me with it? Yep. Now they're starting to say, what do we do next? Well, the only way I can tell for sure, Guy, if you have obstructive sleep apnea is not just your snoring and then making the noise. we need a sleep test. So let's get that ordered up. And off we go.
Absolutely. Yeah, one real recent example of this hope is we went to a physician's, a primary care's office this week, and his team members said, we can't get people to get the sleep test because they don't want a CPAP. So they don't have that hope that there's a treatment that they can tolerate. So they won't even go for the test because they think the only solution is the CPAP. And we heard those exact words.
So right.
Come
right.
out of a physician's office just this week as we went to their office. And if you get the word out that, look, there's hope, you don't have to necessarily have a CPAP, then the patient will get tested. But they don't want the treatment, so they're not going to get the test. They have to realize there's hope. I really like that, Mark. That's I haven't looked at it that way, and I appreciate it.
I wish we had a better answer right now, but there are still a lot of physicians who we feel like we're going up against a wall with them on that. And it's not really an us versus them. CPAP is a good therapy for the patients that can need it and tolerate it, but oral appliance therapy just has so much higher of a compliance, and that really impacts the effectiveness so much. So I think they're coming around. They're slowly coming around. You got some housekeeping slides there.
Yeah, just take a moment. Keep the questions coming in. I see someone's talking about the chat. Put the questions in the question box. Our DS3 team will answer them. Mark and I will get to all of them before the night's over. If they don't answer them, we have a whole team of people answering the questions. You can get CE for this. You'll get it in your inbox within 48 hours. We'll give it 48 hours. If you don't see it, please check your spam. That will mean that most of you will get the CE. So if for some reason you don't, then contact us. But you should get the CE. And Mark's going to be talking about his billing procedures here in just a few moments. He's got a unique way of doing this. I don't know if unique. He has his way, which I've done the way you're doing it. And, but dental sleep billing, there's a lot of information. There's a lot of ways to get to the same end. And Rich and I are going to talk about this on our next webinar. It's usually our most popular webinar. We'll bring up the way you're doing it. We'll talk about other methods as well. So if you want to know more about billing, that's a whole webinar, even a whole day. We're doing a whole day course on this. If you want to know about that, type in billing course. We're doing one in October for a whole day. So it's a long subject, but we'll get through a lot of it here coming up in a few weeks next month in October. And Mark, you've been to our symposium in the past. It's a fourth year coming.
Awesome.
Jason Tierney has outdone himself yet again this year, putting together just a slew of incredibly, I mean, I would say it's the who's of dental sleep medicine will be at this meeting in sunny Clearwater, Florida, February. It's a day and a half, really pragmatic information there this year.
You know, if I can say something about it, I would say that I was pleasantly surprised. I often go to some of these things and I think to myself, well, there isn't going to be a lot of stuff for me. There was plenty of stuff there for a very advanced dental sleep medicine practitioner. There was also stuff for beginners and people that are just getting into it. So I don't know how you and Jason and Richard do it, but you got a nice blend of a little bit of something for everybody there. Well done.
Yeah, and Jason's even, I don't know how he's done this. He's even got Ryan Holiday coming. That's our newest, it's going to be our keynote speaker, best-selling author. I know a lot of you have read his books. I actually brought one of his books with me to read on my trips that I'm maybe taking in the next few months. So it's going to be a great time. I can tell you it's really one of the best meetings, and it's a lot of camaraderie. All the vendors it's just a really open meeting. Hope to see you there. And people ask us, what do we do? What does Dental Sleep Solutions? What is DS3? And Mark, you and I have known each other a long time, and you started out, I think, on a different path at one point before you started with us. Did you not?
Yeah. So my answer to what you all do is, and I say this to anybody who'll sit down and listen, and I'm not compensated at all for what I'm about to say. I don't get any special consideration or anything from you all, but I felt like you all saved my life because I was spending so much time. You've heard me say this. We would get done with patients, and I work in these half-day chunks. We'd get done with a half-day chunk, and I'd have an hour, hour and a half, hour, 45 minutes worth of paperwork to do because I didn't have a software system because I wasn't that busy yet. I was just getting started back into dental sleep medicine. And I thought, well, I can write the letters, and I can keep the notes. And so I've got all these Google files and Google Docs, and I've got them in a secured section. And it was cumbersome to say the least. And so as we were getting busier and busier, I set my office manager, Kim, on getting out there and taking a look and interviewing all the different companies. And each software has its little differences, and it's worth looking at all of them. But we jumped on board with you all just back in January, and honest to God, I told you before we went on the air, I got done today with my patients. I had about 5 or 6 patients we finished up with, and I sat down after the last 2 consults, and the notes were in there, templates were filled out. I made one little change on one little. It took me 2 minutes, 45 seconds each, something like that. Finished up my day, closed my laptop, and went out and jumped in my car and took a phone call on the way home. So it's a real blessing. I guess the only advice I'd give to somebody is, because I suffered for a while, for a long time, with not having a software solution, and DS3 certainly gave me that, is I would not wait to get the software solution. It's not like it's terribly expensive or anything like that. It's not like dental software that's going to cost you, $20,000, $30,000. It's so inexpensive that I would get the solution right away. Right as you're getting started, get those SOAP notes in there the right way, get the studies all stored the right way, make sure you're doing a great job in your documentation and templating, everything like that, and it will just streamline and de-stress it. The two stressors in dental sleep medicine are all the documentation and communication you've got, and you need that to be able to talk to physicians, and billing. And so I would say this one is easy. You just check the box. Billing, you got to find the right company and get comfortable with them. We use yours, and so that they're getting us paid, and so that's good. You just can't do that yourself. That's my plug.
Well, thanks. If anybody wants to know more, just type in consultation. We'll be happy to talk to you about what we do or answer your questions anytime throughout the rest of the webinar. Thanks. You helped me out a lot in my dental career, so I'm glad that my and our company's efforts have been able to help you out. It's an honor to hear that you're so happy with what we're doing. So, man, we got the first 3 steps. I think those are, you've really put these in the order that, I think it's essential, the way that the patient's really hyped up now. They're ready to get, they're hopeful, and we're going to move on to let you know how this is going to work in the office. I think step 4,
so
I believe. If you go to
the next slide, when I use the word usual, customer, and reasonable, I guess what I'm kind of saying is I'm not talking so much about the fee schedule that's UCR or something like that, but when I'm giving them hope, and I'm transferring them to the story, and life is about engaging stories and people believing in stories and resonating with that story and identifying with that story. As I say, maybe I put my hand on their shoulder, maybe I don't. I try to read the situation, and I say, Guy, I wouldn't worry. The first thing we have to do is we need to get a sleep test so we can figure out if you've got obstructive sleep apnea. But don't worry, if you do, if it's mild or moderate, the treatment is easy. We've got the Grow Appliances. I show them one. I said, and we've treated hundreds of people just like you with great, great, great success. I want them to be relaxed. I want them to know that it's usual, customary, and reasonable for them to expect good success. That this is a pathway that lots of other people are on. I might make mention that historically dentistry has not been working very well with physicians. We are now. Physicians used to just refer people for CPAP therapy. Now the physicians we're working with are a lot more open to the mild, moderate treatments, going oral appliance therapy first. So I want them to feel that this is usual, it's customary, it's reasonable. I want them to know that this is something we do all the time and we're very successful at it. I want them to have confidence in me. I haven't had anybody really say to me, well, could I talk to somebody who's undergone the therapy? But I've got lots of people. We've got testimonials on the website. We've got testimonials we could send them, people they could call. Plus, a lot of them have been referred in by other people with the same sort of situation. Or the dentist who's referring them has made some mention about how successful he is with the therapy. I want them to know this is usual. It's common. 20 to 25% of the population has some sort of, breathing, challenging kind of situation.
Act like you've done it before, too, along the way, right? Act like you've done
it before. Even if it's only your 5th one.
Right, and your office has done it before. Really, there's ways of doing that, treating your own team members as you get comfortable. But I know some of that comes with experience, but most of it comes with the confidence that this is, back to my 6 slides, that you believe you can and should do this, and we'll get through it together. It is extremely important that those patients realize that this is not something that you just do once every 6 months and dust off the old equipment when you need it.
Colonel Philip Neal from the U.S. Army, I did some training for them out at Fort Hood down in Fort Sam Houston down in San Antonio, Texas. And he's a great guy, and we got to talking about it. He was talking with all the different dentists in the room, and he reminded these young dentists in the room, these, mostly captains, a few lieutenants, mostly captains, some majors, and they're just getting into dental sleep medicine. They're nervous like we are when we're getting started in dental sleep medicine. He said to them, remember, you can always tell your patients so that they're comfortable with this, that you've done a number of these. He goes, one is a number. One is a number.
Like
zero is a number. I've done a number of these. I've done a number of these just like yours. One, but I've done a number of them, so I like
there
that.
you go.
Most people, I've done a number of these. Coverage. Let's go ahead and talk about insurance coverage, because that's always a touchy subject for people. When you think about the different patient pathways again, you've got to remember that we're not doing dentistry. And so if your patient is looking at you as their dentist, and you let that discussion or conversation sound or feel like it's dental and dental insurance, and you use the same terms about co-payments, deductibles, you're out of pocket, the whole situation starts to break down. If I made a patient sign how much they might owe if insurance doesn't cover it, my success ratio would drop off dramatically. But if we just treated those patients, told them it's covered by their medical insurance, and we went down that pathway, they're much more likely to say yes. Is there a possibility that one of them, once in a while, might be a payment problem? Yes. But if I get 10 or 15 or 20 more yeses and one of them doesn't pay, I am so far ahead from a case acceptance standpoint, I could even accept that tiny bit of a loss. The biggest thing, though, is I'm so used to medicine saying, we're going to draw some blood today. They don't say how much it's going to cost, whether or not you've met your deductible, what your co-payment's going to be. They don't say anything. We're going to need to get an MRI. We're going to need to get an X-ray of that. They don't go, the X-ray is going to cost this much. Here's how much is covered by your insurance. There's no discussion of that. And now I'm talking about drawing blood and X-rays. Screw that. My wife had a tingly thing down her arm a couple years ago. We were in Las Vegas for a trip. And while we're there, she's got this tingling down her arm. We went over at the emergency room in the hospital. We're there about 27 hours. They did an MRI, an MRA, never heard of that, CAT scan. They did a Doppler of her neck. They did an MS test, a number of other things, drew blood, all kinds of stuff. The total bill was $23,000.
Wow.
Emergency room visit to find out that they didn't know. They checked everything they could. It turns out maybe she slept wrong for a week or so, and maybe she was getting some pinching in her arm. We're still not sure what it was, but it's all gone away. But $23,000. No one ever said, we're going to do an MRI. That's going to be $5,500. Your co-payment's going to be this. Your deductible is going to be this. They ran through $23,000 worth of stuff because it was important to us. It was important to them. So if we're trying to answer those first three questions, did Denise have something? Was it serious? Is there anything they can do about it? We were willing to not ask or answer any questions about $23,000. Now, don't mishear me. Don't mishear me. Sometimes a patient will ask about the money. They're not really asking about the money. Most patients, when they ask about the money, are asking about, is this covered by my medical, or is this dental insurance? Is this come out? How does this work? What box does this fit in? So I would say my experience has been, of all the patients we've ever talked about, like saying, let's go ahead and let's get the sleep test, let's go ahead and let's get started on this, take some impressions, get a bite registration. It's covered by medical insurance. They go, okay, and 50%, we don't have an exact number, but I'm telling you, 50%, we just go. We just go. I would say of the other 50%, about half of them, so 25% of the total go, so what does all this cost? What does all this cost? They're not really asking the cost. They just want to know it's covered by their medical. So I say, well, it's covered by your medical insurance. And it depends on your deductible and your co-payments. They go, okay. They're done right there. Now that 75% of my patients, I'm not really talking about the money. The other 25% really do want to know. And so when they do, we move over to that money talk conversation. And I'm not saying this is going to work perfectly for everybody. You and I have had this conversation for how we handle it, but I love what we do. We tell the patients covered by their medical insurance. If they ask about money, we deflect first, and we remind them that it's covered by their medical insurance, and half of those people go, okay. And if somebody says, well, I really want to know what this is going to cost me, here's what we say. We tell them that your maximum, say it depends on your deductible and your co-payment, but your maximum out-of-pocket experience will be a number. But we don't just tell them the numbers. So let's say I bill this much for a sleep device, but my prepayment discount is this much, and I want to make that to be about what's covered by one of the most prominent insurance companies in my area. We have Blue Cross all over the place around here. So I say to patients, talk about your medical insurance, what's it really going to cost me? I want to know out of pocket. And I say, well, the most it can cost you out of pocket, depending on your deductible and stuff like that, is, and I say some number, whatever it is, let's say it's $2,453. I go, because that's what Blue Cross pays. Now listen to that statement.
Right. Tying it to the insurance.
The most it's going to cost you out of pocket is this number, because that's what insurance approves for that particular activity. Now, I used insurance to my favor there, because I said there's a third party who's verifying that that's the right number. Now, if I were to say it's going to cost you this much, and that was more than what insurance is normally covered, they're still going to have some risk, or I still got a discussion to have, or I still got to explain that or validate it. But if I say the most it can cost you is what the insurance company would have covered in network, they go, okay. And I mean, almost never, we don't close 100%, but we are darn close. We get a sleep test back, it's positive. I know, Kimmy could give you the numbers, but I know we do 90+% of those people, we move on to an appliance if they're not getting CPAP. And when we have those discussions, when I throw that out there like that, it's the same discussion you have for the sleep test. Don't worry, the most it can cost you out of pocket is, and there's a nice little number that the prepayment discount allows you to do on that pre-treatment, that pre-sleep test. So the money talk, having a validation like insurance saying that number is okay, man, it gives you just instant credibility with the patient. That's like the government or insurance. Somebody else set that fee, not you. Peace of mind.
Yeah, and again, we're going to talk about this for an hour, the next webinar. And I think some of the key points are is that you have to have a plan. I mean, this is one way of doing it. And you've got to have a plan that you can look at the patient in the eye, and your team can look at the patient in the eye and say, I believe in this. This is the fair and reasonable way of doing it. And you've got to be a plan that's consistent and works in each of those situations. And that works for you. The one thing you have to do, because I've done your plan in the past, is you have to have good follow-up. Because you've kicked the can down the road a little bit here is what you've done. And you've got to have
you're absolutely right.
The follow-up, make sure you do the follow-up billing. Make sure you have verbal skills for when they do owe money, what you do in that situation. And that can be a whole nother part of maybe the conversation we'll add into our next meeting. And it's a very good way of doing it, but you got to have those systems in place down the road. We will talk in the next webinar about other ways of doing it, but I'll give you a sneak preview of the webinar. You have to
do
have
that. That'd be great.
You have to have a plan. And there's a lot of different ways of doing this, and they all work if done and have pros and cons and so forth. I like what you're talking about here. I know you've got a situation where you did some consulting. We'll talk about, how you turned a practice around recently with this. And I think this is a way that's not abnormal at all in the medical, in your medical business. No. And I'll say one more thing, and I don't want us to run over because of this, but if the doctors went and gave everyone a treatment plan for their heart cath, for their exams and all this, no one would ever get treatment and everybody would be dying. And so they intentionally don't do this because they just care about getting the test that they need. And we'll worry about the money later because this is important. Let's worry about the money later. And that's what's different because, look, I'm originally from Kentucky. Teeth aren't all that important. There's a lot of old obese people in Kentucky, a lot of teeth missing. I mean, it is important, but it's not as important as breathing and all these things. So that's why it's different. I think that's where the dentists miss it, is in the medical world. Hey, we got to do this, and then we worry about it later.
That's right. In the moment we start to have the discussion about money first, it makes it sound like, if you can afford it, you can do this.
Right.
Or if you want to spend as much money, you can do it. No, This has to be done. I love your analogy. You're kicking the can down the road, so you do have to have the verbal skills. You got to be able to collect the money. But the thing is, if you don't kick the can down the road, and we want this assurance that we're going to get paid 100% of the time when we do this, you're going to do a lot less sleep.
And you're going to help a lot less people. I mean, and that's the goal here. I mean, I think back to believing in this, I want to help my patients. And so if that means some of them don't pay me, but I help them, I still make my house payment. I still have a nice boat. I still get to go on vacation, and I help someone live. I mean, what's wrong with that? And so I think you've just got to believe in it, and these systems will work, and you will get paid for the majority of them. So I like your approach to this.
And doing it this way it could feel a little risky to a dentist who's thinking like a dentist, but if you do the math, and I would admit we've got pretty good verbal skills. We're doing probably about 4 devices a week in our 2 half days. You know, we're seeing several consults, getting sleep tests started. We're doing several impressions. We're delivering about 4 devices a week. I'm only working 1 day, but we do 4 devices a week. In the last year, we've had 1 patient that hasn't paid us.
Yeah, I mean,
1. So yes, it's going to happen, but I bet I've got 20 or 30 more devices or 50 more devices that I've done and been paid for because I wasn't too strict about the financial arrangements. If I'd been really strict, I probably wouldn't have done very many of those. Cool.
Okay.
All right. Next slide. Well, my final step is expectation. So go ahead and flip the next slide, and this is kind of a fun one, and it kind of comes back to your belief slide when we talk about that. If you argue for your limitations, they will be yours. If you say, I can't do that because I really need to know that everybody's going to pay me, or I really need to have sound financial documents. I worked with a practice not too long ago, just doing dental sleep, that made every single patient sign the financial arrangement that said how much they might owe based on what they were able to find out about the insurance. But it was pretty clear. It was all laid out. Co-payments, deductibles, your amount's going to be, and it would say that. They'd have to sign that and make a down payment or a deposit to get the impressions in the bite taken.
Right.
That is like building a wall between you and wanting to do that. And so we broke down that wall and we changed that. I couldn't say this any clearer than thinking back to your side. Believe, believe, believe. All of those things that you said. But it's not just thinking like a medical model. It's you have to personally be passionate and believe that this is something to support. And your team has to be there and support that. You also have to have the payment, and you have to set up expectations for yourself and how you want to do this. And if that's saying that 1 half day a week I'm going to do sleep, you have to have a team that's committed. So they have to be able to flip that switch if you're going from sleep patient to dental patient, or you've set aside a half day. We all have to be able to flip our switch, change colors, put on our hats, and make sure that we're thinking like that. And the patient has to get there. We have to help the patient know that, oh, you're still talking to me, and last time you were in, we were getting your teeth cleaned and talking about 2 crowns and your dental insurance. Erase that right now. Now it's you and I talking about this health thing that's covered by your medical insurance, and I happen to be the DME provider who delivers this device under the guidance from a physician, and we got to put that in a different box. So you've got to be there, your team's got to be there, patients got to get there, and you've got to set expectations for the payment. And I think we've had great success with helping practices when they talk about their fees and they talk about their maximum out of pocket, they talk about their prepayment discounts. I've said, what's your best insurance carrier payment? And whatever that is, I go, could you live with that as your maximum out of pocket? And if they say they can, and I'm in network with a bunch of different insurances, so sometimes it's higher and lower, but I pick Blue Cross because it's all over the map. And if I use Blue Cross as my standard of care and say that's what they pay, then I'm going to be pretty successful at having those patients accept that number. And the final thing is I would go in with the expectation that 9 out of 10 people, not 100%, that's not a reasonable expectation, but I would expect 9 out of 10 people that either came in with a prescription or you got them through a sleep test and now they have a prescription for an oral appliance therapy, they have a medical necessity to get this therapy done. We should close 9 out of 10 of those. 9 out of 10 of those people should move forward. So if you're at 5 out of 10 or you're at 3 out of 10, you should be asking yourself, how can I go back, look at those diagrams that we went through, and how can I impact those different steps along the way to help the patient move along that sales funnel? What am I doing to help that patient have their questions answered about their disease state?
So you're saying 90+% of the people don't want to choke to death at night or die in their sleep or have a heart attack or stroke. That sounds pretty reasonable to me.
I think there's still going to be that one oddball that's going to want to. So I can't fix that. I can't fix everything.
Can't fix stupid, I guess. But I mean, it really comes down to that. I think we're going to close with your last slide in a minute. Just we talked about some things we can do. Here's something for free for you. I know you've been in this magazine in the past. It's a free magazine that comes. So here's something for free. Come right to dentalsleepinsider.com. You can see all the past 30-something issues that we've done. There's videos, articles. It's real practical information. One just came out I think today, or it was
Today.
today, wasn't it? Yes.
Today.
And you know,
It's got an article by a very handsome guy that is
oh,
doing
I
a
did an
webinar with
article.
you
No,
today.
no, no, I did a video. Never mind. You're talking about yourself. Okay, sorry. You did an article in it, I know, and it's a great magazine. Go back and look at the old issues if you sign up. It'll come to you once a quarter. Thank Jason Tierney and Kelly are people that put that
Do a
together.
great job.
It's
They do a
fantastic.
great job.
And
The
go ahead.
the only other thing I was thinking is because I saw the questions popping up over there. I'm taking a look. A few people have asked me for my copy of my 8 slides. If you email me, my email will be on the last slide as well. If you email me at mmurphy@prosomnus.com and just say slides or 8 slides or whatever that would be, I'll go ahead and send those out to you. I'll send them in PowerPoint format so you can change them around and put your own logo or whatever else you want in that. I won't send them in PDFs. It's a small enough file that you should be able to get that. So well, thank you for jumping to this last slide, because I've done a lot of consulting in dental practices on practice management. I've taught down at Pankey for a lot of time, and I replaced Imtiaz Manji at Mercer Advisors when he went over to Spear, did all their webinars or their leadership weekends and their programs for about 4.5 years. Had a good time. I've applied a lot of that same kind of knowledge now to sleep, and I'm having a fun time doing a little bit of consulting. You and Rich are doing a great job with the offices you work with. But the thing is, I'm not going to win 100% of the time. We talked about increasing case acceptance by 50%. This is a case where we more than tripled it. We increased case acceptance by 300%. So this was an office. It's real data from real office that we were working with. That was the 3 months previous to us spending some time with them. They were closing about 22% of the patients that came in. Of the patients that had a prescription, they get to prescription, they were closing 22%. They just accidentally, with good intentions, built some barriers by putting some systems in place that helped them but didn't help the patient get to yes. We made some really simple changes, and they went from 22 to I can tell you, because you know who we're talking about, is
I saw the data myself.
75% closure rate. So you know they're not at 90. They're not where they want to be yet. They're not where I want them to be yet, where I think they can be. But man, they're a heck of a lot better off. And this is a large practice that just does sleep. So they were making money and paying their bills before. So now I should have done this on a percentage of growth, I guess. I'd have made a lot more money. But and it was fun to do. So you've got my email right down there at the bottom. So please email me if you want the slides. I'm happy to send those out. If you got any other questions and I'd follow up, you know, I'm always happy to do that. Guy, thank you so much for having me on tonight.
Thanks for being on here.
You did a great job.
Well, it was an honor to have you on here. Again, if anyone wants to know more about what we do at Dental Sleep Solution, just type in consultation or consult, and we can meet with you, tell you how we can help you. Because I know you talked about the software, but we also have screening, testing, treating, and billing. There are the 4 pillars we talk about, but then we have the 4 steps where we help educate, support software, and we help with insurance billing as well. So anything you want to know, that's what we do. We have a whole team of people every morning.
You go into some offices as well too, where you spend a couple of days with them and do some stuff. Tell me a little bit about that. What are you doing?
Well, we have you know, the software, as you know, helps you manage all this data. And so we started with the software saying we needed the software, Rich and I, in our practices to make this work. And that's why we built the software. And then we started offering it to other people, and they go, great, now how do I use it? You know, software. Right. And so we started with, so we added on our education. Well, now I can't get paid, so we added on the billing. Oh, well, I can't communicate with sleep tests, so we added on communication with sleep tests. So DS3, as it is today, is a product of about, I guess, going on 10 years of us helping dentists do this and us using the backbone as our software, but adding education support systems for all the dentists that they need, because they need to learn how to do this as they go. We have online study clubs. And then for the members who want even more, I mean, you go through our training. It's all online. It's very reasonable and inexpensive. You have access to online study clubs, meetings. But for people who really want more, we have a program where we go to your offices, you come to our offices, we meet monthly, and we really, you know, the practices that we're working with, and we limit these practices to really grow them. They're really putting an effort towards dental sleep. They want to make it a big part of their practice. They say, you know, we want to just get on the fast train for this. And so that's what I'm doing here in Cape Cod today and tomorrow and the next day, rather. And we have a handful a year that we allow to come into this program. There's a vetting process because we're, in a sense, in a relationship for about 3 years.
Gotcha.
So, if you're interested in that too, it's called our DS360 Premier Tier Program. Just type that in or ask anyone at Dental Sleep Solution. They can point you in the right direction. So our goal, Mark, I think you've known me long enough to know that, we want to, we didn't just provide dentistry because we want to pay the bill. Yes, we want to pay the bill, but we want to go to work. I remember you telling me, I remember your exact words 20 years ago. You don't want someone just throwing the check at you. Thanks a lot. That's no way to live. You don't feel good in the end of the day. You want the patient to come up and hug you, bring you cookies. Thank you. I love my teeth. And
gratitude and
that's
appreciation.
That's the way I ran my dental sleep practice as well. And now that's the way we run Dental Sleep Solutions. We want our members to thank us for helping them help their patients breathe better, live longer, and treat their airways. And so that's what we do every day to get up. That's what my life's involved mostly, is helping other dentists do this. And it's very rewarding because webinars like this, there might be people that are breathing and living better and longer just because of this hour that we spent here together. So I think it's a worthwhile experience. Did we get to all the questions? I know our team's been going through them all. I want to take a quick look just to see, because I did promise everyone we would get to them. It looks like there's a lot of check marks here. I think there's one I saw here about a pre-authorization. Patients, do I use the stop bang? We do, but I use our tablet screener. Someone asked me here.
Yeah.
And one question Stan here asked about is what do we do if the devices may not work? You can read the rest of it, but he's worried about what happens if the device.
Well, I've got an answer for that.
Oh, good.
I got an answer for that. So I had a patient today right at the end of my day, and she's done CPAP, and she was talking about wanting oral appliance therapy, and she said to me, and I really want to make sure that this works before I go through this oral appliance therapy and spend my money on that. I said, well, I wish I could give you that guarantee. Just like CPAP didn't work for you for a different reason, oral appliance therapy does not work for everybody. And so I said, I can tell you that we have certain success rates with mild, moderate, severe, but those are just data systems. Those are just numbers. It doesn't mean anything if you. I said, so, I can tell you all that information you want, but at the end of the day, it's worth trying because it's going to help save your life. And if you can't wear an oral appliance, then you have to go back to CPAP. Right. So in dentistry, we're used to saying a patient comes to us and the tooth is broken, and we put a filling in it and the filling breaks, and we do a crown for free, or we do a root canal for free, and we feel like it's our responsibility. Medicine doesn't do that. If I do oral appliance therapy for somebody, I'm always talking to them about, the statistics, the rate, all the kind of things you're doing. And if it doesn't work, I'll try everything I can to get it to work, but if it doesn't work, that's not my fault. We don't have a selection committee that's perfect for picking who is an oral appliance therapy candidate and who's not. And so that's their risk too. The unfortunate thing is sometimes there'll be insurance companies who'll pay for one therapy or the other, but not both. Sort of like the same and similar in reverse. We'll see that, but that's just unfortunate.
I have an answer to that too, similar but a little bit different. First of all, back to take off your dental hat, put on your medical hat. Okay.
So right.
Because in medicine, there's no guarantees ever. All we do is nurse you along until you die. All the procedures help for some period of time. There's no guarantees for anything you do in medicine. So if you just put that hat on, right, that's like your shield, you should be okay. But understanding what else do you do? I tell the patient, look, I cannot, I'll use the Walter Haley promise thing. Remember that from years ago? He said the promise.
I do remember
statement, something like my version of that. Look, I cannot promise that this is going to solve or treat your apnea successfully. We're going to define what we consider success, and I promise you, I will do everything I can to achieve that success. And if we can't, I promise you, I will help you find other options, most likely CPAP. That's your promise for me. But I cannot, promise that it's going to work for everybody because it's a medical procedure. And if a doctor promise you it's going to work, you don't leave that office slowly. You run and sprint out of the office because no one can promise you that your CPAP's going to work, a dental device is going to work, that you're going to be here tomorrow. Right. Okay, so that's the two things. Put your hat on and promise them that, I can't promise it's going to work, but I promise you I'll do everything I can within my power to get this to work if it's a possibility for you. So it's a tough question. It's one that comes up a lot, and I think you've got to get out of your own way a little bit on that one and just get the right mindset too. And I know it's
my daughter works with me in my office, Kim, and she is a really good coach. She and my wife are really good coaches to remind me that sometimes it's not about me, it's not about the treatment. Sometimes these things just don't work. Now, if the world has about a 75% success rate with oral appliance therapy, and I was having 37%, something's wrong with me.
Right.
But if I'm having the kind of success rate overall with therapy, then that 1 out of 4 that doesn't get a good result, a severe patient, that's going to happen. We've got a great batting average with mild, a really good batting average with moderate, and it drops way down to about 50-50 with severe. That's the end of the story.
Yeah, and you know what? 50-50 is about where we are with CPAP when you look at compliance. So, and no one's beating themselves up over that too much. So, again, it's a mindset. Great question. A lot of good questions here, Mark. I think that was the last one. There was something about a pre-authorization. Those are important. I will put the carrot. We'll talk about that in October at the billing webinar. It's important. There's a lot of paperwork that goes along with billing. So it's having a system like you put together as far as what our system is. But then there's a lot of paperwork that goes along with it, no matter how you're going to do it.
Yeah.
And we're going to address that in addition to the various ways that you can do this in your practice, including the way that you mentioned ways we've done. And you've got to just pick the one that's comfortable for you. But I can tell you this 22 to got a lot of stuff on my screen to 75, I think it says here, right? It's pretty impressive. And again, I saw those numbers, the pre-numbers, not the post numbers. So I'm excited for you and the client you're working with there. Again, Mark, I just want to thank you for taking the time. It's an honor to be talking with you after all these years. And I'm so thrilled that you saw the light and got involved in sleep and have joined in this quest. And hopefully we can do this again someday.
Thank you, Guy. Thanks again for your software. Oh, my God. Saved my life, brother.
All right. Have a good night.
Peace.